Pregnancy is a generative process. A Miss Universe contestant some years ago even mentioned that it is part of the essence of a woman. Pregnancy, especially those that are planned, are considered hallmarks of family, survival, continuation of genes and chromosomes, and more importantly, happiness and self-fulfillment dynamics. Pregnancy, however, is not always a pleasant event and experience. Pregnancy with complication can be as detrimental to the mother as it is to the newborn. Outcomes can range from mild and severe abnormalities to unfortunate death of the mother, baby, or both. Not a lot of studies can be made on a pregnant woman. Health risks are involved. Most pregnant women opt to resort to tried and tested methods to avoiding doing harm to the baby. It is safe to say that every new study is accepted with discerning disposition and complex reviews. A lot of people are committed to protecting an infant-anticipating woman and little bundle of life she is nurturing inside her. We explore today the most common complication reported during pregnancy, and is showing to be the second leading cause of maternal death. We call it pregnancy-induced hypertension, or PIH. Simply described, PIH is hypertension with proteinuria and edema, experienced from the 20th week of pregnancy. The earlier its onset, the worse will be the pregnancy outcome. Hypertension marker is a good blood pressure of 140/90, or more measured onto two occasions measured 6 hours apart. The etiology of PIH is still unknown and ranges from loss of resistance to angiotensin II, thromboxemic, and other factors still being studied and researched. One thing, however, that is hypertension jeopardizes the well-being of the mother as well as the fetus. The three hallmark signs are headaches, epigastric pain, and visual changes. The underlying mechanism of vasospasm and hypoperfusion can lead to pulmonary edema, oliguria, seizures, thrombocytopenia, and abnormal liver enzymes. Hypertension also causes fatal hypoxia and malnutrition and places the baby at risk for prematurity. PIH hypertension with proteinuria can be classified as preeclampsia, which can be a mild or severe depending on the protein levels in the urine and presence of other symptoms. And eclampsia, which indicates the presence of seizures. Seizures are due to vasoconstrictions allowing overexcitability of the brain. American Pregnancy Association's risk factors includes first-time mom, a reported PIH in the family where mothers and sisters had conditions, extremes of maternal age from 18 to 35, multifatal pregnancies and history high blood pressure and kidney disease during the pregnancy stage. Other women who are also at risk are those with chromosomal structural anomalies, history of preeclampsia, GTD, and gestational diabetes, those under chronic stress, those from lower socioeconomic group and has poor nutrition, and women from African American ethnicity. A recent study from the University of Bergen and Norwegian Institute of Public Health added another risk population. Pregnant women who were born small for their gestational age, clinically referred to as SGA.
The study assessed whether women who were born SGA have increased risk for PIH and whether the same risk applies to a father who was also born SGA. Generational data from Norway spanning the years 1967 to 2005 were used. First and second pregnancies within 1998 to 2005 of SGA-born female and male parents were studied and odd ratios were adjusted for smoking and maternal age. SGA birth weights were grouped into less than 2.5, 2.5 to 5, and 5 to 9.9 birth weight percentiles.
Women who were both the fifth birth weight percentile were 2 or 3 times more likely to have preeclampsia with onset of 34 weeks of gestational than those with birth weight between the 25th and 75th 75th, percentile, or those who were appropriate for gestational age for PIHA. Father's birth weight for gestational age was not associated with mother's development of PIH.
Project Viva sought to examine association of first trimester intake of certain foods with preeclampsia and gestational hypertension.
Intake of calcium N3 and N6 fatty acids, trans fatty acids, magnesium, folate, vitamin C, D, and E was studied.
We support a potential benefit for elongated N3 fatty acids in preventing preeclampsia. A clinical trial that was well designed and randomized by Corinne Koopman and her colleagues were done to compare induction of labor with expected monitoring for gestational hypertension and preeclampsia between 36 and 41 weeks gestation. There was a better outcome in the group that had induction of labor. We have noted that induction at 37 weeks gestation and beyond seems to improve obstetric outcomes in patients having and experiencing gestational hypertension and preeclampsia.
She was always complaining of headaches, and I didn't always mind her because I thought she was getting headaches from dealing with me. And yes, she also complained or blurred vision. During one of her prenatal checkups, her blood pressure shot up to 140/90, and after a series of tests, my wife was diagnosed with preeclampsia. She gave birth at 36 weeks, but they were saying it was 33 to 34 weeks of gestations only. They said delivery is cure. My baby was taken immediately to NICU for interventions. He was small, and they had to intubate him. It is true that PIH complicates the well-being of both the mother and the baby. My message to my wife: thank you for giving me a wonderful kid and a wonderful family. I love you.